So this is the crash course in teaching diagnostic reasoning. This is part two, a primer on on the science of reasoning. Now, I think this is really critical, and I would encourage people that are teaching diagnostic reasoning to think about this stuff. Is it always super practical? That's up for debate. So you may find that this is a little over your heads and a little too sciencey, a little too, meta for you, but hopefully people find this practical. So let's first start with the two major theories that inform how we think about diagnostic reasoning. I didn't come up with these. These are way more brilliant people than me. There is dual process theory, which says that there are two major types of reasoning your brain does. One is more of an intuitive type of reasoning, and the other is more of a systematic, deliberate type of reasoning. Then the other major theory we're going to talk about is cognitive load theory, which says your brain can only handle so much load, which is divided into three types of load. Intrinsic, which is related to the demands of the task you're doing. Extrinsic, which is related to things outside your control, external demands, external stressors, and then germane load, which is really thinking during the process of thinking. Pretty meta, right? All right. So let's start with dual process theory. I like to start with a non-medical decision because I think it makes a little more sense, and you can see how it relates clinically as well. So system one reasoning is automated, intuitive, fast, effortless, efficient. It's really the type of reasoning that is invoked when I ask you if you want to play this game. I'll bet you $10 I can guess your birthday. Well, if I ask you to play that game, your intuitive answer is to say yes, right? Unless I'm a stalker or somehow have some other way to figure out your birthday, if I met you on the street and asked you to play this game, the odds are I'm going to lose this game, and almost anybody would take me up on this bet. System two, though, would be required to think about a more complicated gambling game. So let's say I came up to you on the street and said, hey, I want to play a gambling game with you. I have 10 cards in the deck. 3 are blue, 3 are red, 2 are yellow, 1 is orange, 1 is green. And if you draw a green card, you win $50. But if you draw an orange card, you pay me $40. And if you draw a yellow card, you win $60. That game gets really complicated. And even if you wanted to sit down with the rule book of this game, you'd have to do a lot of math and really think hard about whether or not this was a game worth playing, whether or not I'm trying to screw you, or you actually might win a fair bit of money playing this game with me. Now, sometimes these gambling examples, our system one and system two are in conflict. This is the tension of our intuitive and our rational sides. So if I said I have 3 envelopes and inside one envelope is a $10,000 check, the other 2 envelopes are empty. If you choose the envelope with the check, you keep it. But if you choose an empty envelope, you pay me $3,000. Well, the expected gain from this game is actually that you're going to win a lot of money. And if you were able to play this game 100 times, you would certainly come out ahead. But if you're only going to play it one time, there's a good chance you could lose $3,000. In fact, there's a 2 in 3 chance you could win $3,000. So even though you do the math here, the utility is that you're going to come out $4,000 ahead. Most people say, hey, I'm not going to play that game, particularly if you offer this game to a poor med student or a relatively poor resident. However, if you reframe that game as a game with a lot less, where the stakes are much lower, and you say inside one envelope is the $10 bill, and the other 2 envelopes are empty, and if you pick an empty envelope, you only pay me $3, well, now a lot more people are going to play that game. Even though the utility is lower, right? The expected gain here is only $4 or something on that order. Don't check my math. That's off the cuff. But, the stakes are much lower, so people are more inclined to play. Intuition is saying, hey, I'm not going to worry so much if I lose $3. So these things are often in conflict, but let's talk a little bit more about how we use it clinically. So here's dual process theory with a couple of cases. A 60-year-old man comes in with hypertension, hyperlipidemia, heavy tobacco abuse, and he presents with crushing chest pain radiating to both arms. Well, that might be an easy pattern recognition thing for people that have seen any number of patients with acute myocardial infarction. However, if I gave you a 60-year-old man with weight loss, intermittent fevers, eosinophilia, blurry vision, and burning in both feet, well, I don't know about you, but nothing really comes to mind intuitively there. So this is sort of a type of pattern recognition, right? If we recognize the pattern, the reasoning we do is often system one thinking. It's automated, it's intuitive, it's fast, it's effortless, it's efficient, it's reflexive, however you want to call it. It's a very simple automated task. But when we don't recognize the pattern, we have to use a lot of analysis, right? We have to slow down, think more deliberately. Now, the reality is in clinical practice, we're probably often jumping between these two. So even if you get a very straightforward case of an acute myocardial infarction, you might have system 2 kick in and say, hold on a second, am I missing something? Particularly if you're interventional cardiologist, you might think, hold on, maybe there's something amiss here before I just wheel them away to the cath lab. Some people call that a toggle function. Cross-Carey calls it a toggle function, the part of your brain that switches back and forth between system 1 and system 2. The other term I want to introduce here is what's called calibration, which is the perfect harmony of intuition and analysis. And this comes with reflecting on cases after the diagnostic outcome is known. You can say, hey, did I use my intuition right? Did I use my analysis right? And really the goal, I think, of clinicians trying to solve cases, but also for learners, is to be able to be in perfect harmony, using intuition and analysis in a good balance. So it's important to think about how different learners think, right? So if you have an early clinical learner, they're not going to recognize a lot of patterns. So if they're seeing patients in clinic, they won't recognize that a patient with acute onset big toe pain and the toe is warm is gout necessarily. And they may need to use a lot of system 2 analytical slow reasoning to even solve these simple cases. And you have to think about that as you're teaching these people because they're using a lot of brain power to solve what seems relatively intuitive to you. Now, if you deal a lot with more advanced novices, third and fourth year students, for example, or maybe interns, might fit this mold. They might be overconfident advanced novices, and they might think they recognize patterns when they are really not recognizing a pattern. And then that's very cognitively easy for them. So they'll say, hey, wait, that was easy. It was intuitive. I've got it. But they often have underdeveloped system 2 reasoning, and particularly a toggle function that's going to put the check on system 1 and say, hey, are you missing something? Similarly, if you have an overworked, experienced clinician, they might fall into the same trap. And it's not because they don't know better, but it's just because they're stressed or they're under pressure or they're under time pressures. They are exhausted. They can't think clearly. So they think they might recognize a pattern, and they are relying heavily on system 1 thinking when they're tired. But again, because they're exhausted, stressed, whatever that is, the toggle function, system 2, etc., are not able to kick in and check that system 1 reasoning. So it's important to recognize that neither system is perfect. So system 1 is nonlinear, it's intuitive, it's efficient, and it's effective for most problems, but it's prone to bias. Again, if you're tired, your brain's going to kick in and say, hey, this is easier than you think, man. There are different types of biases that trick us into that type of thinking that we'll talk about in a later talk. System 2 reasoning isn't perfect though either. So you could be systematic, you could be deliberate, but that's often inefficient. And in fact, for some cases, it's completely unnecessary. So if that man walks in with crushing chest pain and he's a smoker and he has ST segment elevation on his EKG, you really should not be doing a whole lot of system 2 reasoning. That patient probably needs to get to the cath lab. And you might have one simple question in your mind, am I sure am I not missing something else? But that patient is still going to go to the cath lab, right? So sometimes really extensive system 2 reasoning is going to really ruin your diagnostic thought process. And in the end, system 2 really is partially dependent on system 1. You can only think hard, long, and analytically for so long before you have to start using some cognitively more easy steps, which is using your intuitive reasoning to improve how you're using your system 2 reasoning. And we'll see some examples of that. In fact, we'll see that right now. So if I have a patient in whom I don't recognize the pattern, weight loss, fevers, eosinophilia, blurry vision, burning in both feet, I might try to work through an analysis of this, but my system 1 will say, hold on, this is really difficult. I still am not figuring out how to put this together. So can I simplify this? And my system 1 will be very happy when I simplify the problem as a middle-aged man with eosinophilia, because from there, I might be able to think through a more limited set of possibilities, and then I can go back and say, hey, now can I find the pattern? All right, so that's what I'm going to say about dual process theory for now. Let's talk about cognitive load theory. So here's how your brain processes sensory information. It goes into a sensory memory. So sights and sounds come in, and you have this very effervescent, very temporary, very fleeting sensory memory. But if you decide to pay attention to something, you can now capitalize on your working memory. Working memory still is not high capacity, and it's still brief. It only lasts a few minutes at most. And it has limited capacity, and you've probably heard this rule of 7. You can only think about 7 things in your mind at a given time and juggle those 7 different things. So you then need another layer of your memory to kick in and crosstalk with, and that is your long-term memory. Now, your long-term memory is theoretically limitless, but it's not directly accessible. In fact, you have to pull from your long-term memory into your working memory for it to be of any use to you whatsoever. And this crosstalk is called retrieval and storage. So if you're trying to solve a complex case, you're going to pull from your long-term memory into your working memory. And once you've solved that difficult case, you're going to store that in your brain and long-term memory in a way that even we can't even articulate, right? That's sort of the magic that happens in the brain. So when I go back to the example of this system 2 and system 1 reasoning, I might have this middle-aged man with eosinophilia that I simplified the problem, and now I can use my sensory memory more, and I might pull different elements from my long-term memory or different data elements in the environment and juggle those in my working memory, which can only handle a handful of things. So we talked about the 3 types of loads briefly initially, but let's talk a little bit more about how they apply to teaching diagnostic reasoning. The first is intrinsic load, which is what comes from the demands of the task. And that's driven primarily by clinical complexity and task complexity. In other words, the number of data points you need to look at, how related those data points are, the number of instructions in the task. So if you're trying to teach diagnostic reasoning in a classroom setting and the instructions for solving the case are so difficult, it's going to really pull from the learner's ability to solve the case because the instructions are so complicated. They don't have a whole lot of brain power left to think about how they're going to solve the case. Similarly, if you gave somebody a bunch of random data points, that's really hard to process. But if those data points are related in some way, particularly if you're doing diagnostic reasoning, you can start to see those patterns emerge. There's much less intrinsic load to handle that. Intrinsic learning is driven primarily by the environment. As we're thinking about teaching diagnostic reasoning, that's the learning environment. So that might be a classroom setting, in which case it might be more manageable. But if it's a clinical setting, that's often difficult to manage, right? There are interruptions, there are pages, there are alarm bells going off. Whatever that is, it might be difficult to manage that extrinsic load. The final load is, I guess, a little contentious when you talk to experts, but it's called germane load. This is thinking on thinking. And this is only really accessible if intrinsic load and extrinsic load are manageable. So germane load is driven by brain resource availability and also a little bit about by motivation. If I don't want to think about how I'm going to think, I'm just not going to do it. And the goal here in teaching diagnostic reasoning is to maximize our ability to reflect, learn, and organize our knowledge, right? If we're going to get anything out of a reasoning exercise, we need to have germane load freed up. So I'm going to put dual process theory and cognitive load theory together in an example here now. So let's say I'm seeing a patient. I'm going to have sensory inputs, right? There's going to be sights, sounds. The patient's going to be talking to me. They're going to be giving me some data points, and I'm going to be juggling that information in my working memory. And I might recognize the pattern. And if I recognize the pattern, I'm now going to do some automated intuitive reasoning. I'm going to arrive at a temporary diagnostic hypothesis. And at that point, my germane load is readily available, right? The intrinsic load is low. It's intuition, right? I've solved the case relatively simply. So now I have some germane load that can be freed up for thinking about my toggle function, for example. Am I missing something here? I can start to actively engage my system too a little bit. And that's because I've got some germane load here to use. On the other hand, if I don't recognize the pattern, I'm going to be using analytical slow reasoning. And that's going to have a high intrinsic load, right? It's going to take a lot of brain power to try to solve this case. So I don't have a whole lot of germane load to think about this case anymore, to think about how I'm thinking. I'm just going to be bogged down in analysis. So system one might come to the rescue a little bit and say, hey, can I simplify this problem a little bit and free up a little bit more germane load so I can think about how I'm thinking? So I might reframe the problem in a way then that now starts to balance system one and system two reasoning a little bit better, such that I've freed up some load for my germane load. So I've lessened my intrinsic load in the case, and now I'm able to think a little bit more about how I'm thinking. That's important for not only reflecting on reasoning in the process of solving a case, but ultimately for learning, right? I want to reduce the intrinsic load so that my learner now has some germane load to think about, wow, what did I learn from this case, and how can I store this better in my memory? So in the end, I want to just leave you with a couple thoughts about how you can use these theories to give feedback to learners. Dual process theory is very helpful for thinking about how we think. When learners jump to some sort of an intuitive answer, you might say, hey, have you considered some other possibilities? Maybe your system one reasoning is a little bit too active here, and you should engage system two and think about this a little more carefully. On the other hand, sometimes you might see learners overcomplicating the case and working through lots of possibilities and overanalyzing things. You might say, hold on a second, this is not something you need to have system two waste so much energy on. You might be overcomplicating this patient, and ask them to use a little bit more system one reasoning instead. Similarly, here's some ways you can give feedback to the learner when you're thinking about cognitive load theory. If the learner is struggling with a lot of data points, you say, hold on, let's simplify the task here, and that's something you'll need to do for them. If the extrinsic load is high, you might try to limit distractions. And if the germane load is high, you might say, hold on a second, you're thinking about thinking too much. Let's think about how you got here with the last patient so you're not really stuck in overthinking about how you're thinking. Does that make sense? Not so much. All right, anyways, hopefully that was helpful. That's the introduction to how we think about thinking.